say.
We're starting the head and neck lab evaluation checkoff list. We need the appropriate preparation.
Hi, my name is Linda. I'm going to be your nursing student today. I'm here to do a head and neck exam on you. It should take about 15 minutes, and it's going to involve some touching. Is that okay with you?
Yes.
We also would be collecting the correct equipment, including the pen light, otoscope, tongue depressor, and gloves. We begin by asking history questions pertinent to the head and neck. We ask more detailed questions about areas of patient complaints. So these might include questions that investigate headaches, head injury, dizziness, neck pain or limited range of motion, numbness or tingling, lumps or swelling, difficulty swallowing, or a history of smoking, and a history of head or neck surgery. Also any history of eye, ear, nose, mouth, or throat problems. We will inspect and palpate the head next. For an adult, we assess the shape by placing your fingers in the person's hair and palpating the scalp. You should detect no tenderness, lumps, depressions, or protrusions.
Your tenderness?
No.
We will also inspect the scalp and hair for texture, condition, lesions, hair distribution, or foreign matter. Next, inspect the face by inspecting the alignment and symmetry of the eyes, the lids, the brows. Note the skin color and check that the facial expression is symmetrical with movement.
Could you smile for me, please?
Also, observe any involuntary movements, edema, or lesions. Next, we're going to observe for lid lag.
Could you look down, please?
Note that the upper eyelid continues to overlap the superior part of the iris, even during downward movement. You should not see a white rim of sclera between the lid and the iris. If noted, this is termed lid lag.
Okay.
Now we're going to look at the appearance of the conjunctiva and sclera. We're going to ask the person to look up. Using your thumbs, slide the lower lids down along the bony orbital rim. Take care not to push against the eyeball. Inspect the exposed area. The eyeball looks moist and glossy. Numerous small blood vessels normally show through the transparent conjunctiva. Otherwise, the conjunctiva are clear and show the normal color of the structure below, pink over the lower lids and white over the sclera. Note any color change, swelling, or lesions. Now we're going to inspect the ears. Inspect and palpate the external ears and the mastoid. We're going to observe alignment of the ears and the eyes. Inspect the external nose, checking patency of the nares.
Can you occlude one nose ring? Take a deep breath in and out, and do it on the other side. Okay.
Inspect the lips and membranes for hydration and color. Next, we're going to palpate the sinuses. Using your thumbs, press the frontal sinuses by pressing up and under the eyebrows, and then over the maxillary sinuses below the cheekbones. Take care not to press directly on the eyeballs. We're now going to inspect the neck for symmetry, color, skin lesions. The head for this exam is positioned centered in the midline, and the accessory neck muscles should be symmetric. The head should be held erect and still. Next, we're going to look at the thyroid using the anterior approach. We're going to be palpating it. Now, you can use a posterior approach as the alternate. In this video, we're demonstrating the anterior approach. We ask the patient to tip the head forward and slightly to their right. And we're going to palpate gently the thyroid, both sides, and
Okay.
we will ask the patient to swallow while we're doing this.
Straight. Swallow.
Next, we're going to look at the trachea and palpate the trachea. Normally, the trachea is midline. Place your index finger on the trachea in the sternal notch and slip it off to each side. Note any deviation from the midline. We're now palpating the lymph nodes using a gentle circular motion. And your finger pads palpate. The pre-auricular nodes are located in front of the ear. The posterior auricular nodes lie superficial to the mastoid process. The occipital nodes are felt at the base of the skull. The submental nodes are midline structures behind the tip of the mandible. The submandibular nodes are found halfway between the angle of the mandible and its tip. The tonsillar or jugulo-digastric nodes exist under the angle of the mandible. Now we move to the cervical nodes. The superficial cervical nodes overlay the sternomastoid muscle. The deep cervical nodes are deep under the sternomastoid muscle. You locate the posterior cervical nodes in the posterior triangle along the edge of the trapezius muscle. The supraclavicular nodes are located just above and behind the clavicle, and the infraclavicular nodes are located just below the clavicle.
Okay, tenderness.
Next is the temporomandibular joint. The temporomandibular joint is just below the temporal artery and anterior to the tragus. Palpate the joint as the person opens the mouth and note normally smooth movement with no limitation or tenderness.
Open. Close. Any pain or tenderness?
No.
We're now going to observe for smoothness and clarity of the cornea and lens. Using oblique lighting, we shine a light from the side across the cornea and check for smoothness and clarity. This oblique light views highlights and any abnormal irregularities in the corneal surface. Observe for the corneal light reflex with the Hirschberg test. We're assessing the parallel alignment of the eye axes by shining a light towards the person's eyes. We direct the person to stare straight ahead as you hold the light about 12 inches away. Note the reflection of the light on the corneas. It should be in exactly the same spot on each eye. Next, we're going to observe the pupil size and shape. We observe that the pupils are round, regular, and equal size. We're next going to observe the pupillary light reflex. To test the pupillary light reflex, you usually need to darken the room and ask the person to gaze in the distance.
Straight ahead.
This dilates the pupils. Advance the light in from the side and note the response. Normally, you will see constriction of the same-sided pupil, called the direct light reflex,
Direct.
and a simultaneous constriction of the other pupil, a consensual light reflex.
Consensual.
We would repeat the pupillary direct and consensual test on the other side. Next, we're going to observe for accommodation. We test this by asking the person to focus on a distant object. This process dilates the pupils. Then have the person shift the gaze to a near object, such as your finger, held about 3 inches from the person's nose.
Look straight ahead at that white light for me. And then look at my finger. Look straight ahead. Look at my finger.
A normal response includes pupillary constriction and convergence of the eyes, axes of the eyes.
Okay. Look straight ahead at the white light. And then look at my finger.
Next, we're going to test for the visual fields. It's also called the confrontation test. And this is really a gross measure of peripheral vision. We ask the patient to look at our eyes and tell you when he or she can see your fingers.
Look at my eyes. And let me know when you can see my fingers.
You extend your arm so your hand is posterior to the patient's head.
Yes.
And slowly bring it forward until the patient tells you he can see your fingers. Repeat this on the other side, all the sides, and from inferior and superior direction. Some providers will use wiggling fingers from the 4 directions as well. Should you suspect a defect, you would proceed with testing one eye at a time to establish the defect borders. Next, we're going to test extraocular motion, also known as the diagnostic positions test. This test leads the eyes through the 6 cardinal positions of gaze and will elicit any muscle weakness during movement. Ask the patient to hold the head steady and to follow the movement of your finger, pen, or penlight only with the eyes.
Hold your head steady and just follow with your eyes. Hold for a second for a nystagmus check.
The provider holds the target back about 12 inches so the person can focus on it comfortably. The provider also holds the lateral positions to check for any nystagmus, a fine oscillating movement best seen around the iris. Mild nystagmus at an extreme lateral gaze is normal. Nystagmus at any other position is not. We also check for gross auditory acuity, but our screening for a hearing deficit really begins during the entire history. How well does this person hear conversational speech? You can also ask the person directly if he or she thinks there is a hearing difficulty. We will now proceed with the ear exam. We ensure that the speculum is in place on the otoscope. Hold the otoscope upside down along your fingers and have the dorsa, the back of your hand, along the person's cheek, braced to steady the otoscope. Now this position will feel awkward to you only at first. It prevents you from forceful insertion. Your stabilizing hand acts as a protecting lever if the person suddenly moves ahead. Pull the pinna up and back on an adult or an older child. This helps straighten the S shape of the canal. Pull the pinna down on the infant and a younger child, and a child younger than 3 years. Continue to hold the pinna gently but firmly. Do not release traction on the ear until you have finished the examination and the otoscope is removed. Gently lift up the tip of the nose with your finger and use a light source to inspect the nasal mucosa, noting its normal red color and smooth, moist surface. Note any swelling, discharge, bleeding, or foreign bodies. Using the pen light or otoscope, gauze, and or tongue depressor, inspect and palpate the tongue, buccal mucosa, gums, and teeth.
Say ah. Ah.
Check the tongue for color, surface characteristics, and moisture. The color is pink and even. The dorsal surface is normally roughened from the papillae. A thin white coating may be present. Ask the person to touch the tongue to the roof of the mouth. Its ventral surface looks smooth and glistening and shows veins. Saliva should be present. Shine your light up to the roof of the mouth.
Touch your hand.
The more anterior hard palate is white with irregular transverse rugae. The posterior soft palate is pinker, smooth and upwardly mobile. Let's repeat, asking the person to say ah, and
Okay.
note
Stretch your tongue
the
out.
soft palate
Say
and
ah.
uvula rise in the midline.
Ah. Did you get that?
With your light, observe the oval, rough surface tonsils behind the anterior tonsillar pillar. Their color is the same pink as the oral mucosa, and their surface is peppered with indentations or crypts. Tonsils are graded in size as follows: 1+ visible, 2+ halfway between the tonsillar pillars and the uvula, 3+ is touching the uvula, and 4+ is touching each other. Enlarge your view of the posterior pharyngeal wall by depressing the tongue with a tongue blade. Push down about halfway on the tongue. Press slightly off center to avoid eliciting the gag reflex. Some people have a gag reflex that is easily triggered simply with slight downward pressure on the tongue depressor. There is no need in a screening exam to fully elicit a gag reflex. Another test for visual acuity is using the Snellen eye chart. Position the person on a mark exactly 20 feet from the Snellen eye chart. The person will use either an opaque card or an eye shield to cover one eye at a time during the test. If the person wears glasses or contact lenses, leave them on. We remove only reading glasses because they will blur distance vision. Ask the person to read through the chart to the smallest line of letters possible, encouraging them to try the next smallest line also. We use a Snellen picture chart for people who cannot read letters.
Go ahead and cover your right eye for me, please. And can you read number 7, the line number 7?
F-E-L-O-P-Z-D.
Okay, could you try next line?
D-E-F-P-O-T-E-C.
Good. Could you cover your left eye, please? And could you read this line?
D-E-F-P-O-T-E-C.
How about this line?
L-E-F-O-D-P-C-T.
Once you were finished with the exam, you would wash your hands, describe your findings to the patient as appropriate, and provide any related health promotion teaching specific to the head, neck, ears, or eyes, nose, mouth, or throat.